Hi, my name is Amy Zhang, and welcome to my presentation on preparing for the influenza season in the United States. This project aims to develop guidelines for a medical agency that's tasked with making decisions as to when and where to send temporary staff to manage the seasonal impact of influenza. These medical workers help address staffing shortages, handle increased patient volume, and implement preventative measures such as vaccination campaigns. Influenza, commonly known as the flu, is a respiratory illness caused by the influenza virus. It typically causes symptoms like fever, headache, runny nose, fatigue, but severe cases can be fatal if left untreated. High numbers of these extreme cases can therefore indicate areas where resources most seriously fall short, which allows for flu to escalate to this degree. By analyzing influenza mortality data, we can create criteria to rank regions or states by urgency of need. Between 2009 to 2017, the U.S. experienced on average 66,906 deaths annually from influenza. Visualizing the distribution of flu deaths in this choropleth map, we can see that these flu deaths are unevenly concentrated across the U.S., and it is elaborating these geographic variations that comprises a large part of this endeavor. When charting the incidences of flu deaths across all the months from between 2009 to 2017, as we do in this line graph here on the bottom, there's a similar U-shaped geometry that emerges on the scale of the year. There's a peak, and then a valley, and then a rise again. And so this is encouraging in that it indicates a general seasonality, predictable seasonality around which preparations can be made. These steep slopes can also offer some sense of how healthcare systems become overwhelmed. In the most extreme years, a caseload can jump up by over 50% from the baseline, such as in 2015. So timing is very important to the effectiveness of the medical agency's plan. Based on historical data, flu season timing is relatively consistent across the various regions of the U.S. While weather conditions do affect flu transmission and geography affects weather, this bar graph that shows regional proportions, it shows them to peak around generally the same time. None of the bands dramatically contradicts the overall shape of bar graph order. And this bar graph orders the months from highest to lowest months on average for flu deaths. January and March are the top months for flu deaths in this bar graph. They're non-consecutive months, so this suggests a dual peak model instead of a single winter peak. The current CDC model describes flu season as occurring in fall and winter, with peak activity between December and February. However, from our line graph, we can actually see that March is the month that has seen the most sustained, consistent increase in flu deaths relative to other states. And also, we can see that winter and spring are the seasons that are most fraught with influenza peril. Their months, the bundle of their months, occupy the majority of the upper portion of the line graph, as we can see, whereas fall and summer tend to be closely bundled on the bottom. So our proposal to the medical agency will be based on a flu season model that includes two peaks instead of just one in January, and it also takes into account this season extension into the spring. As a final note on the flu season, while the season is generally concurrent across the U.S., it does appear that the southern U.S. experiences a larger impact with higher death proportions per bar. However, as we can recall from the earlier map, flu deaths vary widely state by state, even within a region within the South. And what remains is the question about how to refine geographic guidelines for resource allocations. So one approach we explored was prioritizing states based on populations vulnerable to flu mortality. We focused on testing age as a demographic variable with connection to flu death vulnerability, and thus potentially a variable that could help with deciding on allocations state by state. In this box and whisker plot, which visualizes the spread of death counts by age groups, what is highlighted is the disproportionate impact of influenza mortality on older populations, specifically those 65 years and older. As you can see, the box plots for older age groups have a much longer vertical tail, and this indicates incidences of high death count values that exceed those found for younger groups. Our statistical hypothesis taken from this was that states with a larger population of those 65 and older would have higher flu deaths. Our testing confirmed a significant difference with a 95% confidence level between states with a larger versus smaller elderly population. How did we next use this finding, though? We made sure to distinguish between total population size of 65 and older and the individual risk to flu death of someone within this population age group. By calculating flu death rates per 100,000 people in the 65 plus age group, we thus normalized for each state's population, and this helps to reveal true risk levels to the individual. For smaller states, absolute death counts may be low, but the risk per capita can be very high. And as we can see from toggling between these two variables in the tree map visualization, the adjustments produce quite different pictures of urgency. So in the default picture, we're working just with the gross concentration of the elderly population. You can see that California, New York, Texas are the top three. However, once you move to the individual risk, normalized population, you see that Texas, Georgia, in fact, states of the South are highest on the hierarchy of urgency. Okay, there's a quite dramatic rearrangement of the hierarchy once we change those two variables. So once we began working with death rates, though, this normalized metric, it quickly emerged that our first approach of prioritizing by vulnerable age group populations was potentially too fine a grain or too specific. We created a scatter plot that indicated that among the variables for our analysis, the two variables that actually have the strongest correlation is the death rate for the individuals in the age group 65 and older, and the overall death rate for a state across all age groups. The best predictor in many cases of whether an individual 65 and older was more at risk of influenza mortality was whether everyone across all age groups has a higher risk of influenza mortality in that state. So this strongly suggests that there are factors outside of age at play for influenza mortality. And this becomes even more compelling when we consider that there's only a very weak correlation between states with a larger population of 65 years and older individuals and the proportion of their deaths that are comprised by individuals in that age group. It seems to be intuitive that if the population in a state has a larger population of those 65 and older, then the majority of the deaths would be from individuals in this age group. However, that turns out to be quite weak. And there is only a moderate relationship between states that have higher total influenza mortality cases and states that have a larger population of individuals 65 and older. So again, this reinforces the notion that there are other factors outside of age at play. And basically what we're seeing is that the age-based vulnerability that we first perceived is part of a larger trend for states where the risk of death is just higher among all age groups. Our spatial analysis further explores these trends. This choropleth map here illustrates flu deaths from 2009 to 2017 by state, and shows predictably higher death counts in populous states like California and New York, which are more darkly shaded. However, the accompanying symbol map of death rates per 100,000 residents tells a different story. Right? So, in more lightly shaded states, less populous states, you will have a much larger cross, indicating a larger death rate than you would for the inverse. Despite having higher death counts, California's death rate is relatively low, and regions from Texas to the East Coast, and those particularly in the South, show elevated death rates, which supports the notion of systemic vulnerability factors beyond age alone. So in conclusion, we have three main recommendations. The first is to broaden vulnerability assessments beyond age. Our current results indicate that multiple factors, including disparities in healthcare infrastructure, are influencing these outcomes. Incorporating something like spatial analysis of health insurance coverage can provide valuable insights for refining the staffing decisions. Here we have a preliminary analysis using a 2017 CDC flu vaccine survey dataset. Our second recommendation is to expand the priority metric beyond deaths to identify where healthcare systems are most strained. It's not really enough to know mortality rates, to examine patient volume and capacity. And this is because during the flu season, healthcare systems are dealing with cases of influenza-like illness. It's not just the most severe cases. And so high patient volume in emergency rooms or hospitals can serve as a more immediate indicator of where healthcare systems are most strained. And then our third recommendation is to use the specific findings of our research thus far, which have to do with influenza mortality and age vulnerability, use them to plan preventative measures, so vaccination campaigns specifically. So we can use the death data as a proxy for where vulnerable populations are experiencing the most mortality. And this helps us to identify key areas where vaccination campaigns can prevent future deaths from attaining such high counts. The schedule that we propose for these campaigns will be rolled out over the U.S. simultaneously, given the general uniformity of the season. The support volume should be adjusted based on the death rates, historical death rates that we have thus far, and once we acquire a more updated data set, forecasted death rate would be quite useful. And ultimately, the strategy that we're proposing for the medical agency is twofold, to think of the paradigm as twofold. On the one hand, there is staffing for vulnerable populations, and on the other, there's staffing for overwhelmed healthcare systems. They both work together to inform the timing and the focus of the medical support strategy. So for the former, staffing for vulnerable populations, this is the plan that we are most able to elaborate on at this point in time. These preventative measures can be based upon the metrics that we have explored thus far. And then staffing for overwhelmed healthcare systems will require more extended research, and altogether they will make for a comprehensive strategy. So, thank you for your attention.